Good evening to everybody. Thank you, Ms. Jina and Adipolabs for this opportunity. You already heard how hyperthermia works. So what I will do is I'll skip some of the slides and I'll briefly tell you why it is absolutely necessary. You heard how it works, but we need equipments to induce heat. Then we have various techniques of doing that. Why it is absolutely necessary is that unless you manage to heat the tumor, you will not get any of the effects that you generally see in vitro. So inductive heating, radiative heating, capacitive heating, galvanic heating, selective impedance-based heating. I have been using capacitive RF heating for a long time, and unfortunately, this talk is about female malignancies. I have very limited experience in that. My predominant experience in head and neck cancers and other cancers, but nevertheless, we'll review that. So it's very important for us to understand that there are various techniques and various machines to heat, and it's very important to heat unless you heat appropriately in a human being, which is designed to lose heat. We will not see the effects that you're going to looking for. And these are the various ways of doing it. Next, please. Next slide.
Yeah.
Moses, next slide. Oh, okay, because I don't think I can do it from here.
Okay.
No. Yeah, so we have electromagnetic heating, ultrasound heating, conductive heating, and hyperthermic perfusion. Now, how is it relevant? Electromagnetic heating, probably the one which you are being introduced by the Adipolabs, is electromagnetic heating. It heats a tissue in a different way. We need to understand that. We need to be very aware of the techniques that we are using when we are assessing the outcomes of hyperthermia. It's much like protons. The old-fashioned protons are much different, are far more inferior than the contemporary machines of protons. In the same way, we must understand what is that I'm using to heat. Then similarly, ultrasound heating is like what you see in HIFU. HIFU also, it's an ablative heating systems. You can use ultrasound there. And of course, you can use RF-based probes also to ablate, but HIFU is very popular, and especially in South Korea, I think HIFU is very popular. Now, hyperthermic perfusion, when we talk of high tech, and conductive heating is we rarely talk about it now. I don't like the wax and so on and so forth. Next. Yeah, and before that, please. Yeah, so we have two kinds of heating. One is a local regional heating, another the whole body heating. Whole body heating is what you heard previously about, generalized eliciting a generalized immune response. And you have IR system, that's infrared systems to heat the entire body. You can also have water-based systems, and I saw one in Japan and maybe one in China. So I think as long as you know how to heat the whole body very safely, it's also an important method of heating. And all these heating systems are relevant to understand the outcomes due to hyperthermia. Next, please. This is another, 9 centimeters. Well, it's very effective vis-a-vis as compared to 16 centimeters. It's a head and neck tumor. So, very big tumors may have a hypoxic core, which probably needs to be heated. But if we cannot heat adequately, then we're not going to see the outcome. So it's very important for doctors or the clinicians to understand when to heat and when not to heat. So when we heat the right tumors to the right temperature, you get the desired outcome. Next. So you heard all of this. Why is hyperthermia very important? It's like it targets a plasma membrane cytoskeleton nucleus, which is distinct from the sites or the targets for radiation therapy. So when you combine radiation therapy with hyperthermia, it is going to be additive. Next. Well, tissue pH is exceedingly important to understand, and hypoxic and acidic tumors respond much better to hyperthermia and not radiotherapy. So if you cleverly integrate radiotherapy and hyperthermia such that you increase the perfusion, decrease pH, and at the same time heating itself ensures cell kill. Next. So which are the, now let me paraphrase what I've been saying. So if you have a nutrient deprived tissue, if you have poorly perfused tissue with an anaerobic metabolism and lower pH, these are the kinds of tumors which are amenable to hyperthermia. I believe there are skeptics in the audience. Please remember that if you choose this kind of a tumor and then add hyperthermia, you're going to get excellent outcome. So when you're assessing the response, when you're looking at the various literature, various publications, please look for all this. Next. All right. Now, chemotherapy combined with radiotherapy and hyperthermia probably will give a synergistic or additive effect. But there are three groups of chemotherapy which we need to understand. They act no matter what, and independently of any of the modalities. There are 5-fluorouracil, methotrexate, actinomycin D, and taxanes. So taxanes, methotrexate, and 5-fluorouracil are very, very commonly used medications. Additive is when 1 + 1 is 2. Doxorubicin, cyclophosphamide, ifosfamide, and gemcitabine is additive, and synergistic would be cisplatin, carboplatin, mitomycin, bleomycin. When we come to HIPEC for ovarian cancer, one probably can remember this slide, and especially because mitomycin, bleomycin, and cisplatin are very commonly used drugs when we are talking of HIPEC in ovarian cancer. Next. How does it work? Hyperthermia and chemotherapy increases perfusion, increase production of radicals, increase DNA damage, inhibition of DNA damage repair, reversal of chemoresistance. These are some of the mechanisms by which chemo, radiation, and hyperthermia work when you combine all of them together, and especially when you combine hyperthermia with chemotherapy. Remember, all that we are talking about when we talk of hyperthermia is not a mumbo jumbo. It has a biological basis. It has a technical, supported by technique and technology. And it's not just association, but there is a causation between hyperthermia and the outcome. Next. Of course, you heard about immune response. This is one of that. Next. Now, when we are talking for my topic, a lot of topic is talking about very briefly, not very in great details, about gynecological malignancies, and breast, uterus, ovary, cervix, and vulva are very common gynecological or female cancers. In India, cervix and breast, cervix in a rural setting and cervix in an urban setting is the second. And breast seems to be very common in the urban setting, but not so much in the rural setting. Should we be really bothered about all of this when so many immunotherapy and so on and so forth are being touted or coming up in the market or coming out in the market? Yes, we do. If you look at one of the CS data, the incidence is going up, but the survival rate has stagnated for the last 3 decades. So we need to do something more. We need to do something more, if possible, in all these situations. Next. So breast cancer is an age-old malady. Even 17th, 18th century, it was recognized in this painting. And now, how breast cancer is let's understand, is a systemic disease. So when you're talking of a systemic disease, we need to contextualize local therapies like radiation and hyperthermia. Unfortunately, hyperthermia as of today is not as yet a common integrated treatment along with radiotherapy, say, for instance, after breast conservation or just immediately after mastectomy. But then where do we get hyperthermia in? So this is a patient of mine. It has, as you see, the pigmentation, there's a lot of radiotherapy that has gone in. Obviously, if you look at the scar, this patient had some kind of a mastectomy. And obviously, chemotherapy has been systemic treatment, various systemic chemotherapy have been tried before, but yet we are going to deal with this patient. We are stuck with a recurrent disease. This is the kind of a recurrent disease which probably will be helped by addition of hyperthermia and hyperfractionation, or an appropriate hyperthermia itself. Next, if we combine hyperthermia with chemotherapy or hyperthermia with radiotherapy, you might get excellent outcomes. Now, this is selective hyperthermia trials in breast cancer recurrence, and one which is very outstanding is that by Jones. And this is from Duke's. If you look at it, when you combine hyperthermia radiotherapy to local recurrence, it is 66% local control versus 42.3% for radiotherapy alone. So these are a few of the trials, the phase 1, phase 2, and Jones was one of the landmark trial for phase 3 trial for just for recurrence, which showed a remarkable outcome. And here we are looking at initial response, then overall survival, but then because that is a very complicated one, and Jones was that of a randomized prospective trial. She used adriamycin along with that, if I remember right, or that's another trial. Okay, this is radiotherapy hyperthermia alone. Next. Well, I mean, it also depends as to how many hyperthermia per week has been treated, and if you these people achieved around 40 to 42 degrees Celsius, and median interval between initial radiotherapy, etc., was 36 to 90, and RT dose was 24 to 60, and RT dose per fraction was 1.8 to 4. Next. In that Jones trial, I guess. Yeah, this is a forest chart, and this is by another. This is from a meta-analysis of recurrent chest wall of breast, and if you see, most of the blocks are towards the right, and they favor addition of hyperthermia to radiotherapy. Some of them are retrospective, and I think he analyzed nearly 36 or 33 trials, and he eliminated some, and then eventually he looked at 8 to 10 published data, and which were adequately documented, and they were suitable for analysis. It shows that if you look at the odds ratio and the forest chart, I think addition of hypothermia does enhance a complete response. Yeah. Now I'm very happy that local regional hyperthermia with olaparib. This is one of the trial, phase 1 trial that is listed in 2019. There's unfortunately no active. It's not still recruiting patients, and my earnest hope is that they do recruit patients, and there could be very interesting data because. And a combination of hyperthermia and olaparib has it's a checkpoint inhibitor, can come up with some very, very interesting outcomes. And I thought I was very happy because people are still interested in local regional hyperthermia in breast cancer, and for rightly so, I should say, because breast cancer is a systemic disease. Hyperthermia has not gained so much of traction in this particular area. Next. Well, cancer of the cervix, unlike breast cancer, is predominantly local regional cancer. So we have very good outcomes and it's stage dependent. Next, I'll show you very important ones in the next, please. Next. So I wish I had. Next, we'll go to next. Yeah. Now, just remember this: why the addition of hyperthermia has been shown in vitro. This is very important of neutralizing E6. Neutralization E6 with elimination of human papillomavirus of positive cells. This is very, very important. And there's a G2 arrest, which enhances radiation sensitivity. This information from the laboratory is exceedingly interesting. Next. This is the Dutch trial, which showed that addition of hyperthermia to pelvic tumors and predominantly cervical tumor enhances survival. This is a landmark trial. Next. There is always a dependence of response to the temperature. That's very important. When it's more than 40, response is better, and then when if it's 39 and around, it's not so good, and that's statistically significant. Next, this CTRT with regional hyperthermia also has been tried for downstaging. Next. Not a very good idea if you look at that. This is where it is. Very few patients could be really operated by downstaging, in spite of the fact that 75% of them responded. Next. You can add hypothermia to palliative CTRT. Next. People have tried interstitial hyperthermia with CA cervix as a hyperthermia modality, but that's not a good idea. I thought I'd just tell you that if you want to add hyperthermia to cancer of the cervix, it has to be external beam radiotherapy along with chemoradiation. Next, this is our own small data of cervical cancer, wherein we compared with our own historical controls, our historical comparator, and it's a very small published study, but addition of hyperthermia is feasible and perhaps better. Next. Sorry, intraperitoneal chemotherapy for ovarian cancer. So this is last of my tumor site that I will be discussing. HIPEC has gained immense popularity in India as well. Next. HIPEC is all about giving heated cisplatinum or any of the chemotherapy agents following cytoreduction. And you can see that with 53 months of overall survival, and a median PFS is around 39 months. This is in stage 3, stage 4 ovarian cancer. When you look at this, I think it's a tremendous improvement in ovarian cancer, which receive only systemic chemotherapy. I mean, we can go through it. This is very important. This is what Cochrane tells you. Addition of hyperthermia to radiation plays a complementary role. RTHT leads to increased complete response with a relative risk of 0.56 and lower recurrence stage, hazard ratio is 0.48, improved survival, hazard ratio 0.67. This is Cochrane database. And thank you so much. Next, thank you so much. Next, please. Thank you. These people help me. Some of them are from the Google search. And in brief, in conclusion, hyperthermia works in many of the tumors. Landmark trials are in cervical cancer, and I have predominantly used hyperthermia with radiotherapy and chemotherapy in my practice on RF-based heating system. Of course, my largest data is in head and neck cancer. Thank you so much.